you. Last chance for questions or comments. All right, we'll move on to the next one. Dr. O'Dwyer is here in person with us today, and
Please come up here.
I'm just going to make sure I didn't miss a chat question. I think we're good.
I think I can use.
Can you
Yep,
do that?
I can do that. So I'm Kristen O'Dwyer. I'm a medical oncologist. I hail from the University of Rochester Medical Center in Rochester, New York. So, and I'm a member of the Leukemia Committee, and you might be wondering why we're going to talk about a very rare form of ALL. But in my own clinic, I have several active service members with ALL, and their journey has been has really left an impression on me. And even though they're young adults, they were active duty at the time of their diagnosis. So when we were writing this trial, and once we had it approved, and we're thinking of other patients, and I'll get into why we think the VA committee could help us if you wanted to participate, that it would be a really important study for any young patient who has this really rare but yet curable disease. It just takes quite a bit to cure this. So that is our hope. So we have designed a trial, a randomized phase 2 trial of chemotherapy plus or minus a BCL2 inhibitor therapy for patients with TALL or T lymphoblastic lymphoma. And I am representing just many people who participated in Sharon. We couldn't have done this trial without Sharon, and she's really encouraged us to come and try to present to this committee as well. So just a little bit of background on our recent experience with ALL. So this is the Kaplan-Meier curve for overall survival base for our young adult patients with ALL. We define, or the NCI defines, young adult patients as ages 18 to 39. And at the CALGB 10403 trial was a trial that was led by Dr. Wendy Stock at the University of Chicago. And when she made the seminal observation that young adult patients can benefit from receiving a pediatric inspired approach to their ALL regimen versus the standard adult protocol. And so this was the first trial designed specifically for our young adult patients. So our historical control data for historical outcomes data for young adults treated with an adult type of regimen was about 50% survival. And just by changing the component, not adding a single new drug, no drug had been approved since the 70s for this type of therapy, but just changing the schedules and the dosing of the components in ALL therapy, going from how the pediatricians did it to our adult colleagues, increased the overall survival from about 50% to about 70%. And historically also, there was always a question of, does T cell versus B cell do better or worse? And again, when we adjusted our recipe, so to speak, the outcomes are very similar no matter what phenotype that you have. So TALL, it is a very rare tumor. ALL in general, there's about 6,600 new cases estimated to be diagnosed in 2023. And TALL makes up about 25% of those. So it is rare, but it is primarily a diagnosis of our young adult patients with a median age of 28 years old. And in addition, the male to female incidence is about 3 to 1. There's also a higher incidence in Hispanic and Black populations. So we think that this is a very important area to target. Our prior study, the CALGB 10403, the SEER incidence for ALL and Hispanic populations was about 40%, but our enrollment on CALGB 10403 was only about 15% of represented by Hispanic patients. They are known to have a worse outcome, but if they were actually enrolled on the trial, and there's a publication on this, that if they were more likely to adhere to these prolonged regimens, and then their outcomes were equal to the rest of the study population. So again, we really want to focus on increasing the accrual and benefiting patients who are struggling with this disease. But so back to TALL. So it is curable for children and about 70% of our young adult patients with our contemporary frontline therapies, but around 30% of adult patients will have subclinical disease or MRD following induction and consolidation therapy. And this is our most important factor for relapse, just like in other tumors that you've already talked about. Unlike in B-ALL, where we have a lot of new medicines, especially immunotherapy medicines in the form of antibody therapy and CAR T therapy, we do not have any of that for T-ALL. So we have no good salvage regimens. So once a patient with T-ALL has relapsed, their overall survival is less than 10%. In my own clinic, I have never salvaged a patient with T-ALL. I have never had one survive a relapse. So Nelarabine is the only drug that's FDA approved, and that was approved many years ago for relapse refractory T-ALL. We are now incorporating Nelarabine into our frontline regimen. And like I said, there's no novel immunotherapies or targeted therapies approved yet. There are some very early studies ongoing phase 1 that are developing CAR T, off-the-shelf CAR T, and some auto CAR Ts for T-ALL. But again, they're early phase. So the study design that we came up with was based on evidence from several lymphoid malignancies that use the BCL2 pathway to evade apoptosis. And in T-ALL, what's unique about it, or what's very interesting biologically, is that the maturation state of the T lymphoblast determines the specific BCL2 protein on which it will depend for survival. So for example, in a very immature subtype of T-ALL, something called ETP-ALL, they have higher levels of expression of BCL2 and relatively lower expression of the BCL-XL, while more mature subtypes of T-ALL express lower levels of BCL2 and overexpress BCL-X. So there was a phase 1 study that was conducted for patients with relapsed ALL. And as you know, venetoclax is a selective BCL2 inhibitor, and that's widely used in hematologic malignancies. And navitoclax is a broader BCL2 protein, and it inhibits BCL2, BCL-X, and BCLW. There's a laboratory technique to detect what kind of cell type, their dependencies on which BCL2 protein that they're dependent for cell survival, and that's called BH3 profiling. And this has again shown that in relapse refractory T-ALL, and I'll show you on the next slide, the bulk blast population seems to be more BCL2 dependent at the time of study, but then at the time of progression, it becomes more dependent on BCL-XL. So we thought Dr. Stock thought that combining these two inhibitors would be a rational addition to our frontline therapy. So here's the BH3 profiling data from the phase 1 trial that used venetoclax and navitoclax in relapsed refractory patients. Both B and T-ALL were included, and children were included as well. And you can see in the red box below that those are the T cell patients, and that many of the patients were BCL2 dependent at the time of study entry, even at relapse, but then became BCL-X, or they switched their dependencies. So we really think in T-ALL that this could help us to eliminate resistant populations very early on in the treatment, which is what we think is the most important strategy to prevent relapse. And again, because we don't have good salvage regimens for T-ALL, our strategy is really focused on optimizing that frontline regimen, which you can see here. There's nothing pragmatic about it. I wish we had a pragmatic study like in lung, but we can't get away from a complex multi-cycle, multi-agent chemotherapy frontline regimen for our young adult patients with T-ALL. So this is the study design. There's 3 cohorts. I'll start with cohort 1, which is the largest. It's a 4-arm trial. Originally, it was designed as a 2-arm trial, but the NCI wanted us to really dissect the contribution of each study drug to the backbone regimen. So we went from a 2-arm trial, which was just the combination inhibitor, to chemotherapy, our control arm, which is just the chemotherapy control frontline regimen, and then adding it to venetoclax in arm 2, navitoclax in arm 3, and then in arm 4, there will be the venetoclax, the ven-nav combination. So our primary endpoint is the day 29 MRD negative rate. So all of our MRD, you've talked a lot about MRD today. it will all be done centrally and paid for by the study. We submitted a translational medicine, BIS, the BISQUIC funding. Yes. And Brent Wood, who is an expert at doing flow-based MRD, and he has done the Children's Oncology Group flow-based studies for decades. He will be doing all of our MRD. One of our other translational medicine arm is to do clonoSEQ. So we still need to secure funding for that, but we will collect samples and then we can do that in bulk. But that also will be paid for by the study. The study drugs, we've just last week or the week before got final confirmation from Amgen and AbbVie and Genentech that they are going to contribute both study drugs. So that is also paid for by the study. So we hope that this combination will be safe. We are going to start with a safety run-in because this combination has never been done. So we will follow all 10 patients. The first 10 patients that will be enrolled in this trial will be enrolled to arm non-randomly to arm 4, and we'll watch them through the 4th cycle of high-dose chemotherapy, which DI, delayed intensification. Even though the study drug is only going to be administered for 14 days during induction and 14 days during consolidation, but we'll watch them through all high-dose chemotherapy cycles, which takes around 6 to 8 months in these patients. The reason for that is that there's a little bit of background. Our current young adult trial for B-ALL, which we're incorporating immunotherapy early on in the frontline therapy, there was a toxicity signal in the experimental arm, and that occurred in delayed intensification. And so that trial there's been a pause on that while the study chairs investigated that. And so it's just by the time people get to 6 months in, they're at risk for infection. They were all septic deaths. So we want to be very careful because both navitoclax and venetoclax are very myelosuppressive. We'll have guidelines for prophylactic antibiotics and growth factor support. So it is a complicated trial, but we will also have bi-weekly meetings every 2 weeks. Anyone who has as long as the study investigators agree to participate in these calls, we can open up that safety run into all sites that want to participate. And we'll just have calls and talk about patients every 2 weeks until patients get through that DI course. There's a day 78 marrow MRD assessment as well, because we know that that's also an important time point. TALL has a little bit of different MRD clearance as compared to BALL. It's a little bit slower. But it's also prognostic. So, but the primary endpoint, we hope that we want to clear MRD early. We have another study within the cooperative groups for patients who are MRD positive for TALL that's using daratumumab as an MRD eraser, so to speak. And that's being led by Shara Dinner at Northwestern University. If you have questions about that, we could talk about that. There's 2 other smaller cohorts. TALL also, about 25% of patients will have only mediastinal disease or nodal disease and not have disease in their bone marrow. But these patients are treated the same as TALL. We don't know if that's the right thing to do, but that's what we do. And that's what the COG does as well. So and historically, this group has been excluded from our ALL trials. So we really want to bring them back and start to study them. So again, we'll assess the first 10 patients for safety because they haven't been included historically with these kind of multi-agent long-term chemotherapy regimens. And then the second 10 patients will be non-randomly assigned to receive both experimental agents. We also will have a cohort for older patients. It is rare that an old patient older than 40 has TALL, but we definitely have them in our clinic. And there's no standard of care here. So we want to try to bring all these patients together so that we can decide for trials going forward if we could include them all under one arm. So here's just a summary of our cohorts and the primary endpoints. And again, the safety run-in I already talked about, and the toxicities of interest that we'll be watching. But again, we wanted to bring the leukemia committee here. We have a lot of really interesting trials that we hope we could, if it would help your patients. I know, again, like I said, I have several young men who were in the military at the time of their diagnosis, who then found their way to me, and we end up treating these patients for 3 years. So, it's a long journey for them, but if we can be helpful, or if we can participate in the VA, that would be great. So,
Great. Thank you.
thank you.
Questions online or in the room? Let me make sure I do. I think we're good.
Okay.
So thank you.
Yeah.
Thanks. We are gonna move on. Mike, you're up. We're gonna talk a little bit about our storefront, and then we'll move on to some other things. I'm gonna try to. Perfect.
All right. Thanks for being here Saturday morning. So I'm going to talk a little bit about the VA storefront. So our site kind of started with that Hope Foundation SWOG grant a while ago. Then we used that to get into Navigate. So we're a Navigate site as well. And then we applied for the storefront to see if we can transfer the knowledge that we had to